Vivian, do we have you there? Doesn't seem like it. All right, hello everyone. I'm Susie Whalen. I'm the Outreach and Communications Associate here at PSI. And we are just going to wait one extra minute to let Vivian change her audio. It seems she's had a little error there, but she should be back on in one moment. I'd like to thank everyone for joining us today on this webinar called Best Practices for Running a Pharmacy-Based Drug Take-Back Program. It's sponsored by the U.S. Department of Agriculture, the USDA. And let me see if Vivian has come back on. Vivian, are you there?
Hi, can you hear me, Susie?
Yes, I can. Wonderful.
So I take it that you welcomed everybody.
I did, yep.
Fantastic. Okay, so as Susie may have told you, our webinar today is entitled Best Practices for Running a Pharmacy-Based Drug Take-Back Program. And we are very lucky to have our two pharmacists here with us today to share their insights on what it's like to run this take-back program in a pharmacy. But first, I'd like to give everybody a little background. So this webinar is part of a project funded by a U.S. Department of Agriculture grant that was jointly awarded to two organizations, and the first of those is the New York Product Stewardship Council, which provides leadership and resources to individuals and organizations, as well as local governments and lawmakers, and even manufacturers. And they provide these resources on product stewardship, which, as many of you know, is the act of minimizing health, safety, environmental, and social impacts of products and those products' packaging. And those impacts are throughout the life cycle. So it's about minimizing from start to finish of the product's life and maximizing economic benefits. So NYPSC works in New York State and nationally to educate all of the key stakeholders, including suppliers, retailers, consumers, and especially the product producers. They are educated about the benefits of product stewardship, and NYPSC gives them a forum for the exchange of information about existing policies and programs. The other organization is the Product Stewardship Institute, or PSI, where I'm the lead on our pharmaceuticals work. PSI is a national membership-based nonprofit organization founded in 2000, and our membership and board are made up of governments. So we work with 47 state agencies, as you can see by the extent of blue on this map, and we also work with hundreds of local governments. Like the NYPSC, PSI is committed to reducing the health, safety, and environmental impacts of consumer products across their life cycle, and we focus on sustainable end-of-life management. So we work on about 20 different consumer products, including pharmaceuticals, where we have over a decade of experience, beginning back in 2005 when it became clear that drugs were ending up in waterways and hurting the environment. So when unwanted and expired drugs are flushed down the drain, as many of you know, they travel into the sewage system and then to wastewater treatment facilities that aren't designed to remove these compounds. When they're trashed in the garbage, they can end up in landfills where the leachate enters our soil and eventually reaches waterways, or again, they can go to a wastewater treatment facility and be released into the environment through effluent. But the problem is more complicated than just keeping pharmaceuticals out of the water. It's about the prevalence of pharmaceuticals in the home as well, where they're often being stored inappropriately and thus posing a risk to human health because they can fall into the wrong hands and be accidentally misused or even abused. The increase in prescription drug use and the drug abuse epidemic spreading across the entire U.S. are clear indications that pharmaceutical stewardship is as much a public health issue as it is an environmental one. So pharmaceutical collections, or what we call drug take-back programs, have been identified as a key strategy to getting these medications out of the household medicine cabinets and disposed of safely, both to help cut off this gateway to drug abuse and also to protect it from environmental contamination. So to that end, we have been working on policy to encourage safe and sustainably funded drug disposal at the county, state, and federal level, and we've been running drug take-back pilot programs across the country. Currently, we're finishing up a USDA-funded 6-month-long drug take-back pilot in 5 pharmacies across rural New York State at 2 independent pharmacies in Oneida County, 2 independent pharmacies in Lewis County, and 1 hospital pharmacy in Lewis County. We focused on rural communities for this project because, just like urban areas, they're hurt by the nation's growing drug abuse epidemic, but these areas tend to have fewer convenient drug disposal options for a more dispersed population. So this is our first pilot project operating under the Drug Enforcement Administration's 2014 final rule on the collection of controlled substances, which expanded the types of locations that are allowed to collect controlled substances for disposal to include pharmacies. So NYPSC and PSI are the project leads for this, but we are working closely with a really diverse advisory committee of local experts who have contributed their time and provided incredibly valuable insights towards this project, including those from the Development Authority of the North Country, the Oneida Herkimer Solid Waste Authority, Drug Abuse Prevention and Recovery Centers, environmental advocacy groups, even the Poison Center, law enforcement, and the recycling industry have joined us to help, and 2 county public health agencies have been really active. And at the state level, the environmental department and others have also chimed in. So it's been an incredibly robust group that's provided a critical service to this project. And equally important was the involvement of our 5 pharmacies listed on this slide. These pharmacies volunteered to be collection locations for the project and not only provided the floor space to host a take-back receptacle, but they donated time to train their employees, and throughout the project they provided really valuable feedback to us. We hired Sharps Compliance, Inc., a reverse distributor, to set up a drug take-back receptacle and prepaid mail-back envelopes at each of these pharmacies. And to promote the program, we launched an outreach campaign that our speakers will go into a little more detail about. We also issued a press release and worked with local media to bring attention to the program. And some of our pharmacies took it upon themselves to go above and beyond and really spread the word throughout their community, sometimes even giving interviews for the local news. In order to measure progress on this project, we gathered a few kinds of data. Sharps Compliance, Inc. provided us with collection amounts from each location, both from the mail-back envelopes and the receptacles. And we also ran 2 surveys, a tear-off questionnaire on how participants in the take-back program had heard about the project, and a large-scale phone-based interview of a sample of the population in the region to assess their awareness around the drug disposal issue. And we did that both before and after the project so we could compare our outreach impact. And these all demonstrated the effectiveness of our project's outreach campaign and education to the public, so it was very rewarding. So we had 4 goals for this project that we have met so far with flying colors. We wanted to first increase the availability of safe and convenient drug take-back options in this rural area of New York. Second, we wanted to increase awareness in our target area about the health, safety, and environmental risks associated with improper disposal and storage of pharmaceuticals and how best to dispose of them, so better alternatives. Third, we wanted to see a corresponding increase in the quantity of unwanted medications that were actually collected in Lewis and Oneida counties. And finally, we wanted to establish some best practices for promotion and outreach, but also for running these programs overall. So to meet our outreach goal, we developed an incredible how-to guide, a really comprehensive resource for implementing pharmacy-based take-back programs, which we are happy to announce we are releasing publicly today as a free guide. So take-back can be realized in pharmacies nationwide. So towards the end of the webinar, I'll give you all a sneak peek of our how-to guide, and I'll provide you with the web address so you can view that and download it for yourself, or so you can share that link with your network. But before we come to that, I'd like to introduce today's webinar speakers. two very experienced pharmacists who will guide us through their process of setting up and running a drug take-back program. We have Diane Loftus, Director of Pharmacy at Lewis County General Hospital in New York, and we have Brianna Flynn, Pharmacy Manager at the Falls Pharmacy in New York. As I mentioned, I will be discussing some key lessons learned that PSI and NYPSC gleaned from running this project, and these are included in our how-to guide. So I will also be your moderator today. I'll compile your questions as they come in, and in the end, I'll ask them of our speakers after they're finished with their presentations. We'll give a nice amount of time to Q&A. So before we get started, just to ensure things run smoothly for everyone, I'm going to turn it over to PSI's Susie Whalen to provide you with some logistical information about the webinar.
Thanks, Vivian. Hi again, everyone. I'm just going to go over a few how-to items for you to make sure the webinar runs smoothly. So first off, if you have any technical questions at all, say you're wondering why your audio isn't working or you can't see something right, you should go down to the bottom right-hand corner of your screen where it says Q&A. You can select from that Q&A box all panelists from the pull-down options. Then type your question into the field below and hit send. My colleagues Megan Byers and Amanda Nicholson will be there to answer your technical questions and help you get up to speed. Now, if you have a content-related question, say you have a clarification question about something that Diane or Brianna presented in their presentation, you should follow that same step-by-step process and go down to the Q&A box on the bottom right, type in your question, and hit send. Be sure to send your question to all panelists, not to an individual panelist, because you might risk having your question go unnoticed. And with that, I want to thank you all for joining the webinar, and I will hand it back to Vivian.
Thanks, Susie. Actually, with that, I'd like to transition right over to our first speaker, Brianna Flynn, Pharmacy Manager from the Falls Pharmacy. Brianna?
Hi, everyone. My name's Brianna. We run the pharmacy. It's opened in 1939, and we are a family-run pharmacy. It's been in the family for 3 generations, and I guess I'll tell you about I'll talk about the program then. All right, we had to modify our DEA registration so we were able to collect controlled substances once we got the drug take-back box from Sharps Compliance. Before that, we were only able to collect other drugs from the companies. None of the controlled substances were collected. In order to change that so it was easier for us to collect and for customers to bring in meds, we changed our DEA, so we were able to do that. And then we'll go to the next slide. We had to apply for a DOT permit through the Department of Transportation so that they were able to take our drugs that we collected and send them to the Sharps Compliance. We had to fill out permits and information for them, but we were able to get that finished up. Go to the next slide. We got the receptacle in and got that implemented into the pharmacy, and then we put up the mailback envelopes right on top of our receptacle. That way, if we had any customers come in that had a few things still at home or knew a few elderly people that couldn't make it into the store but still had meds they wanted to return, they were able to take those mailback envelopes and send their drugs directly to the Sharps Compliance company. It was fairly easy to install the receptacle. It didn't take long at all. We got it all installed per the directions that came right with it and went from there, and it seemed to work out fine. We had a few questions. Customers would come in and weren't exactly sure where it was or were confused if it was outside or inside, but we were able to answer their questions fairly easily. Go to the next slide. Training the employees was fairly easy. They we followed all the regulations and all the paperwork on the Sharps compliance box. We would check it periodically to see if it had gotten full, and then once it was full, we got the new box in the mail and sent out the old one. Go to the next slide. To do that, you unlock the receptacle, you record all your information, you take the old box out and you tie it all off and seal it, and then we have UPS come in and they would take the box and send it right to Sharps Compliance, and then we would fill out part of the new paperwork and have that recorded for putting in the new liner. And then we would just wait for it to fill up again. We knew that you couldn't collect the Sharps, their actual needles or anything, or the inhalants when it came to like inhalers and things. But we were able to collect quite a few over-the-counter meds and pharmaceutical meds in our collection box. Go to the next slide. We implemented the pharmacy bags in our prescriptions that let a lot of the county know and a lot of our customers know that we were able to collect the leftover medications, and they also, with the newspaper and social media, we were able to reach out to more of the county and let them know that we did have the box. And of course, any customers that came in, we also let them know that we did have it so that we could try to get a few more people, get word of mouth out there also. Okay, we'll go to the next slide. We had quite a few different pharmacies that were able to be the drug take-back programs. The closest to us is the Lewis County Hospital, and thankfully they were able to implement that in Lowville. Go to the next. It looks like floor space, it wasn't too much of an issue. It's about the size of, I want to say, well, smaller than an actual like blue mailbox receptacle. Didn't take up very much space at all. It's not awkward or gaudy or anything. The customers are able to clearly see it and see right on the outside what's acceptable, what's not. And again, it didn't take long to train our employees. We just had to make sure they followed all of the rules and regulations and made sure that they kept up with all of the paperwork that went, well, paperwork and filling out the forms that went with it. We were able to reach out to quite a few people. It looks like in August we had our highest rate of drug take back, or drugs taken back. But we had quite a few people coming in throughout the 6-month period and putting them in, and then they would go and tell another family member, and they would bring in more. And again, with the newspaper and the social media, we were able to bring in quite a few different customers and bring in different foot traffic into the pharmacy. All right, and thank you very much.
Can folks hear me? Susie, can you hear me?
We can hear you now, Vivian.
Great. So thanks, Brandon, in case you couldn't hear me talking. Those were really helpful insights. And with that, I'd like to transition to our next speaker to learn a little bit more about setting up a take-back program and to hear about the hospital perspective. So please welcome Diane Loftus, Director of Pharmacy from Lewis County General Hospital. Diane?
Hi, Vivian. Can you hear me okay?
We can hear you great.
All right. As Vivian mentioned, my name is Diane Loftus. I'm the Director of Pharmacy here at the hospital in Lowville. We are a small 25-bed critical access hospital, and I'll just give you just a little bit of information about the facility. We are nestled between the foothills of the Adirondack Mountains and the Tug Hill Plateau. I call it cow country. We're surrounded by farms and agriculture. Our facility itself has a nursing home attached with 160 beds. We have on-site hospice home health care, and we're affiliated with 10 clinics. Next. So back in 2011, I collaborated with Mountain View Prevention Services and our local Lewis County Sheriff's Department to establish a collection program in our community. At this time, there's a lot of paperwork involved. So law enforcement had to be involved, and the facility had to eat the cost of the event. And to make sure there were certain measures in place to prevent diversion and everything, we had to get involved with many different agencies for the approval process. So we had to contact the Bureau of Narcotic Enforcement, New York State Department of Health. The Sheriff's Department had to type up a letter accepting full responsibility for possession and disposal. We had to contact the solid waste facility, get a hauler permit, a swipe card, and we also had to set up an appointment with them for the actual destruction. And then at the end of everything, we had to actually present a letter to the DEC when it was all said and done, which was a signed form witness with the sheriff and the solid waste facility confirming destruction. Next. So overall, the three of us, Mountain View, sheriffs, and the hospital, wanted to really come up with a way to collect unwanted expired medications and help residents dispose of them properly. And the first step we felt was collecting up a safe pill drug collection. So we started to educate the community about medication disposal and non-medical use of prescription drugs, which Mountain View does on a daily basis anyway. And we created a couple of brochures. You can see little screenshots of them there. We really wanted to target the homes so we can get the word out there about curious children, teenagers, confused seniors, and also focus on just getting them out of the cabinets to reduce the amount of drugs entering our waterways as well. Next. So here we have a couple pictures and results from the past several years of our take-back events, and we're very lucky to have help from the Lewis County Sheriff's Department to help make our events successful. We couldn't have done that without them. And the main thing that really kept us coming back was just the interest in the community and the appreciation that everybody showed us. The residents were just so thankful to have such a program so they could get rid of their medications. Part of our success, I'll probably keep mentioning Mountain View Prevention Services. They were a huge part of this. They worked closely with our local Youth Empowerment and Health Community Coalition. They've been trying to get a drop box put in place for quite some time and had not been successful. They had tried going the route of law enforcement, but that didn't really work because there were staffing issues, space issues, and location issues and everything. So when we heard back in 2014 that the DEA published the final rule, we were very excited, and I instantly contacted the DEA so I could get some more information about what I needed to do to become a collector. Next. And Vivian already went over a lot about the 6-month pilot take-back program. But what happened was in the late spring of 2016, I came across a press release from PSI and NYPSC, which announced the drug take-back project I had not heard about previously. And I decided to reach out to them to see if there was any way we could be added as a pilot site. So at that time, I started working closely with Vivian, and shortly after, PSI had developed a survey, and I was able to use that at our drug take-back event to gauge the community's interest in a permanent collection receptacle. I think we collected like 110 surveys, and with proof of our great collection rates, our pictures, and just all the data that PSI collected, we were able to convince the USDA that there was a need in our community. So PSI started to work their magic, and shortly after, there was a budget modification approved for the drug take-back program at our site. Next. So far, we've done very well in this program, and I think most of our success really comes from the successful outreach to the community. So number one, we had the data from the PSI survey, and that helped us determine that the best way to reach the community really was through newspaper, radio advertising, and flyers. So we were able to utilize that data. I'm very lucky to have such a great director of marketing and public relations here at the hospital that I was able to work with because she really helped get the word out. And also, I'm lucky to have such a good relationship with Mountain View Prevention Services director, as they both were very detrimental in getting this out to the community. So once the press release was available, the hospital PSI and NYPSC disseminated this all over New York State to residents, associations, different groups, and local governments. This was distributed to our local coalition, which is comprised of everybody in the community, local businesses, nonprofits, community-based organizations, schools, faith-based organizations, treatment recovery agencies, law enforcement, parents, healthcare field, and just about anybody. So in addition to the press release, we developed a flyer, and we used the flyer developed, the red one there, developed by PSI. And we distributed that to internal staff here at the hospital, to all of our clinic-affiliated clinics, our hospital-affiliated clinics. And I also manually posted some around the facility, sent internal emails to staff, and shared it with the hospital board, and just really tried to get it out there. Also, just like Falls Pharmacy and the other pharmacies, as part of the pilot, we were supplied with prescription bags, and that had the location and the pilot details on them. So we were able to, we're a little bit different than the retail setting, so I distributed these to all of our affiliated physician offices and just left them on the tables and waiting rooms. We gave them to some local agencies just to hand out or have on their tables, hospice, home health care, and we left them in the lobby. Next. So after the press release and everything came out, we reached out to local press and gained commitment from them and the media, the local media editors to publish the information. So after reaching out directly to the media, we had 2 articles published in frequently read county papers. We had 1 news interview. And then once those articles were published from there, we further disseminated them on social media. So we posted the links on Facebook, and from that, we were able to reach a broader audience, and we had our links shared by numerous local agencies, such as the New York State Pollution Prevention Institute, the Lewis County Solid Waste Facility, and many local residents shared that as well, so it was able to help us spread the word. Next. So next, I just want to talk a little bit about the difference in the hospital and how the hospital location is different from a standalone pharmacy location. For the most part, the setup is all the same. You still have to change your registration and go through the DOT permit and all that stuff. The main 3 differences, I think, resolved around the patient's duration of stay, the security level in the facility itself, and your location of the box. So in the retail setting, typically your patients are there for a shorter period of time. The hospitals, we're usually open 24 hours, and we have unsupervised public access, and you never know how long somebody's going to be here, so they may be here for an extended period of time without a known reason. The security level on a lot of levels is the same. They both require the box to be permanently secured, so it can't be removed. You have to have 2 employees to remove the liner and replace the liner. But the main difference here is in the retail setting, most of those pharmacies have different policies in place for theft loss prevention, where the hospitals are much larger and we don't always have theft or loss prevention measures, and routine traffic's not usually monitored. I mean, if you think about it, if you see someone linger around in the retail pharmacy, it may look a little bit suspicious because you know that they usually don't hang around for that long. They're there for a reason and then leave. So in terms of the drop box location, retail pharmacies, as I mentioned, are a little bit smaller, and usually there's a common area where you can clearly see where the drop box is and where your patients are. So you can kind of tell if there's something unlawful going on. The drop box in the retail setting is inside the registered location. It's in immediate proximity of the employee. In the hospital setting, it's not in our view. So we do have to adhere to the general rule to regularly monitor the box, but it doesn't have to be in the direct eyesight of a pharmacist. And one stipulation in the hospital is that the box cannot be in a location where emergency or urgent care is provided, because these areas are usually very chaotic and at increased risk for diversion. Next. So we did run into some challenges during the pilot program, nothing really major. As I mentioned, we're at increased diversion risk because of the location. It's not within our site. We had several patients who wanted to bring in garbage bags full of medication. So that was a challenge for us. We were allotted through the pilot 1 box a month, and on average, we were going through 1 liner a week. And I'll discuss how we got through that in a little bit. So once the box is full, you have to lock it. And then once it was locked, we had patients that were setting bags on the floor and on top of the box, which was an obvious issue. Next. Another challenge I'm still currently facing, because I haven't 100% made up my mind, is trying to decide on the size of the collection receptacle and what our liner schedule needs to be. So we've been in the program, it'll be 3 months at the end of this month, and luckily we were able to increase our liner schedule, so we didn't have to lock the box as much, but I'm still faced with trying to determine how often the liner is going to need to be changed, and the more liners you get a month, the more pricey it is. I also need to determine if we want to continue with the mailback envelopes, or how many we want to order and how readily available to make them, because they also come with a cost. But it's a really good option for us for when the box is full. I like to refer them to pick up an envelope if they have small quantities. And I also think it's a really great option for our home health care and hospice patients as well, because they can't always get out of the house. I'm not familiar with a lot of the contracts with the different companies, but one of the challenges I'm facing right now is, do I really want to sign a lengthy contract? You know, what if my collection rates drop off, or what if I find a company that's going to be much cheaper and then I'm stuck in a 3-year contract? So, I mean, overall, I can get through these challenges, but I can honestly say that without being part of this pilot program, I probably would have never jumped the gun and gotten a box, because everything I looked at, you know, was pretty pricey. I didn't really have lack of knowledge on what was available out there, and I really was just uncertain of what our collection rates would be. So it's kind of hard to commit to something when you have no idea what you're going to collect. So I'm very thankful to everybody that was part of the pilot program, and want to thank PSI, NYPSC, and USDA for allowing us to have this opportunity. Next. So some of the barriers, challenges I mentioned, what we did to address this: number one, the security measures. We have to have regular monitoring, so it's not in our eyesight. What did we do? We implemented walk-arounds. So pharmacy staff, environmental services, and our maintenance department routinely monitor the location of the drop box. And we also installed a camera right on the collection box that's routinely monitored. So it's monitored 24 hours a day. All the footage is recorded. We can look back at any time and zoom in and see if we had any issues. The second thing with the collection quantities I mentioned, we had a larger than expected collection rate. We were going through one liner a week versus one liner a month. And so one of the things we did when patients wanted to bring in their garbage bags full, we suggested that they split them amongst the different area locations that had drop boxes, or we suggested that they do a little bit now and a little bit later. But we also really reminded them that in the spring and in the fall, the DEA still holds their take-back events, so this is a great way for them to still dispose of their medications, especially if they have a lot of medications all at once. When the box is full, we hung up signs on the box that says temporarily closed, referred them to the location where they could get the mail-back envelopes, and try to put a date, like check back next week. Sorry, the box is full. And to maintain the program, which is one of our other barriers, we are a small facility, funds are limited, and I really want to keep the program funded. It's been so well accepted by everybody. I've been in contact with many local agencies throughout this, and they've all shown tremendous support. And surprisingly, many of them are willing to help fund the program. I've had probably 4 agencies reach out to me and tell me, they're happy to, whatever they can do, if they can pay for 2 or 3 months of the program, that they're willing to do that. So right now, our grant writer has been looking for grants and stuff to help support the program, but it looks like it's really going to be a local collaboration, and it's great. We're going to be able to keep it going. Next. So this is what our future looks like. Our survey that we did back in April really showed that 100% of residents would like to utilize a permanent drop box, and 69% would still like to utilize a take-back event. And with some of the challenges we run into, especially with people with large garbage bags full of meds, I think there's still a need in the community to have our annual take-back event, so we're going to continue that in the spring. Hopefully the DEA will keep that up because it's very beneficial. We'll do our spring take-back event, and we're also going to continue with the drop box, and we're very happy about that. And that's it.
Thank you very much, Diane.
You're welcome.
So we, the project leaders, we learned a lot by guiding Diane and Brianna and the other pharmacies through the process of setting up, launching, and promoting their take-back programs. I think that in addition to what we gained, it was really worthwhile for the pharmacies to host these programs. When it came to any training for pharmacies, like the need for there to be 2 employees to change a liner and other such regulations that they had to learn about and implement, or any paperwork that they had to do for the DOT or the DEA, whatever investment they made seemed to be offset by the really great results. Not only did the program collect an estimated 300 pounds of unwanted pharmaceuticals from an area that previously had no way to safely dispose of controlled substances, but it helped engender customer loyalty for these pharmacies and really bring in more foot traffic. Our pharmacies commented frequently how their customers were so satisfied and even impressed with the way they were going above and beyond. So we're really pleased with these results. But I want to step back for a minute and go through a few of the key lessons that we learned through each step in our take-back program, running these programs across all 5 pharmacies throughout rural New York. And I know many of you already have, but please feel free to start sending in your questions if you haven't already. You can type those in on the bottom right, as Susie mentioned earlier. So in undertaking our pilot, the project team, as I mentioned, gathered best practices from our experience in managing this take-back program and other take-back programs. Every time we came across a challenge and found a solution, we made note of that, and we compiled it in a really thorough but easy-to-use how-to guide for drug take-back programs. So it contains everything that a pharmacy or that anyone interested in starting a pharmacy-based take-back program would need to know. In addition to the basic steps and instructions, the guide highlights specific helpful hints and lessons that we've learned by doing. So I'll go through just a sample of those for you now. As Brianna mentioned in her presentation, the pharmacies in our project applied for and were each granted party status to a special permit that the DOT approved to help pharmacies implementing these DEA-sanctioned take-back programs to comply with DOT rules. But it's worth noting that the DOT, the Department of Transportation procedures for compliance are still evolving. And it's possible that in the future, pharmacies won't have to apply for anything. They will be automatically covered under the special permits of reverse distributors they're working with. And in fact, that's already starting to happen. So if a pharmacy is using such a vendor, they would not need to apply for party status to a special permit at all. So one of the key recommendations that we've made coming out of this project, one of the key recommendations we included in our guide is that any pharmacy starting a take-back program should carefully select their vendor and then talk with their vendor before starting down any one path to compliance. Now, when it comes to selecting the right collection system and the right vendor, it's really important to know that some reverse distributors do more than just transport collected material. Some of them also provide receptacles, the physical infrastructure, for rent or for sale. But if not, there are companies dedicated to creating DEA-registered receptacles specifically for this use, for pharmaceutical collection. So our guide provides all the key questions that you want to ask these potential vendors and information on what to consider before you sign a contract. And it also includes a really handy chart with an array of vendors in the form of a matrix, so that you can see what services they each provide, really basic services, as well as a longer list of vendors to consider at the bottom. Once your vendor contract is signed and it's time to set up the program in your pharmacy, it means considering the physical constraints and opportunities of your space. So our guide has a whole section of advice on the regulations around setting up a receptacle, like the fact that it has to be affixed to the floor or to the wall, as well as more practical things to consider, like how much floor space does a pharmacy have available, and will the receptacle be visible? Will the signs be visible? So when it comes time to launch collections and you're all set up and ready to go, there are several lessons we learned through our experiencing actually operating a program that can be really key to success. For example, our guide has a whole section on key resources and information for pharmacy employees so that pharmacies won't have to reinvent the wheel. They'll have an FAQ document, for example, that they can keep behind the counter, like a cheat sheet with all the basics that the employees should be aware of and information they can give to customers when asked. The guide also includes reminders about DEA rules that are really important to follow, like the one I mentioned about 2 employees being involved in emptying out a full receptacle, and the fact that, for example, collected material has to be securely stored if there's going to be a delay before it's handed over to be transported or shipped for destruction. So the guide lays out steps to make that entire process seamless. Once a take-back program launches, its success then relies on it being used, obviously. And it will only be used if the community knows it's there. So the how-to guide dedicates page after page spelling out best practices for outreach, not only giving examples for promotional strategies, but going so far as to provide sample language and outreach material that we've developed in-house by our under the leadership of our communications expert who you've heard from, Susie Whalen. Finally, the guide includes a comprehensive case study about the New York pilot program that we've been talking about, with details about all of the steps we took, our results on cost and collection, and several other details that are worth knowing. It includes an appendix with the standalone fact sheets, like the FAQ document we saw earlier, and even a sample application for DOT party status if that ends up necessary. So it's really everything you need to bring Take Back to life in a pharmacy in your community. And here on the screen, you have the link to access it now. And if you can't write that down, don't worry. We will be following up with all of you after the webinar, so you'll have access to this link through those resources. Now, with that, I'd like to open it up to our audience questions. I've compiled those, so I'll be asking those of our speakers today. So to begin, we have a question from William Grimes stating, we are enrolling 17 pharmacies in October. And if those pharmacies ask, how cumbersome will it be and what is involved in modifying their DEA permit and complying with the DOT? Is it easy? Is it quick? What is the cost, et cetera? So Diane or Brianna, do you have anything to say in response to that question?
Yeah, I can respond, Diane. It's very simple. There's a link online to the DEA. Instructions are in that pamphlet that Vivian was just showing. It's as simple as going on, plugging in your DEA and your information, and changing your status. Do you want to be a collector and have a drug collection box? Do you want to do the mail-back program? Right after you do that, you can print it right off the screen, and they mail you the original a couple days later. And in terms of the DOT permit, it's a little more confusing. I recommend looking at the example in the book, but overall, it's really not bad. It's just looking for main contact information for your facility or the pharmacy.
Yeah, and as I mentioned, it's possible that the standard operating procedures will not be for pharmacies to apply for party status in the future. That's just the situation that our pilot project was in, so we wanted to give instructions in case that's the case. But of course, if you start a pharmacy-based take-back project, or program rather, you should work with your vendor to see whether they've already applied for a special permit that will cover the pharmacy.
Yeah, the most confusing thing about the permit was having to come up with, was it the DUNS number, the DUNS number for the facility? That was the hardest part for me.
So companies are issued a DUNS number through a company called Dun & Bradstreet, and there's a link to more information on that in the how-to guide. But it's basically just a company identifier, and not everybody has that handy, so that's something to think about. So our next question is from Ed. He asks of the pharmacists, was there ever an occasion that you suspected a business put their waste in your box? In other words, did you receive any non-consumer generated drugs in your take-back receptacle? And I'll let both of you answer that one at a time, starting with Diane.
Okay. This was a concern of mine because of our location. We have all the hospital-affiliated clinics, and historically at our take-back events, we've had rehab centers and transitional living centers want to bring their meds back. So the first thing I did is I posted a sign on top of the box stating that this is for residential use only. You know, agency and physician-related waste are not accepted. So have they put them in there? I'm not really sure. We have filled the liners very quickly, but we also are not permitted to go through any of that material or any meds in there, so there's no way to tell. But just to educate people that it's not allowed.
As far as the Falls Pharmacy goes, we didn't notice any other, like they said, companies putting any medications in. But again, like she said, we aren't allowed to actually look through the medication to judge whether they did that or not. But as far as we know, we had none. Had no other people, just residential.
Great, thank you. And a somewhat related question from Maureen Warfield. So sharps and inhalers cannot go into the receptacles, correct? And if so, what do you advise people to do with them? What do you tell your customers?
Well, for our Falls Pharmacy, we are not allowed to collect the inhalers or the sharps. On the inhalers, we had people taking, as long as they're not labeled, and throwing the inhalers out. That was the only other option we came up with because it went right into the garbage. Other than that, with sharps containers, we don't have an actual sharps collection here at the pharmacy. I'm not sure if they do at the hospital or not.
Yeah, so at the hospital, in terms of sharps, the patients can bring their medications to our switchboard, and they'll walk them to a location where they can actually dispose of their sharps, which of course they have to be in hard plastic containers or coffee cans or something like that, so they can't be punctured. In terms of the inhalers, this is one of my questions when we first started collecting. Can we take inhalers? Can we not take inhalers? I don't know if 100% I found a regulation surrounding that. I did see that aerosol spray cans are unacceptable, and I think it depends on who you talk to if you can take it or not. Of course, like anything else, we have no way to actually monitor what's going in those bins. So if asked, I would tell someone to probably utilize the DA take-back event or a household hazardous waste through the solid waste facility.
Yeah, and regarding what's allowed in these receptacles, we're lucky enough to have representatives from Sharps Compliance here on the line with us. So if we could unmute Dustin and see whether he has any comments to speak to that question. Dustin, are you here with us? We'll give him just a second to get unmuted.
I think, Vivian, you and I had this discussion once, and we thought maybe it was state-specific, or different states had different regulations on that.
Yeah, that's a really good point. I mean, with all of the take-back rules and regulations, it's important to consider not just the federal agencies like DEA and DOT, but also state-specific rules. And it's worth noting there are still a small handful of states where take-back at a pharmacy, even though it's legal at the federal level, it's still prohibited at the state level. So if you're among those states, which are listed in our how-to guide, that's definitely something to be aware of at this time. So I think we've unmuted Dustin. Dustin, did you have anything to add?
Yeah, I'm here. Can you hear me, Vivian?
We can hear you.
Excellent. Okay. For the inhalers, we have one of our resident experts on the line here. His name's Joe Jordan, and he can address that. On the receptacles, it does state that aerosols are not to go inside of them, but as many people have mentioned on this call, there's no way to monitor that 24/7 or physically be there to see what people are putting in there. Now, are they supposed to? They're not supposed to, but I'm sure that it has happened. There are different ways to dispose of the inhalers, though. So I don't know if you can possibly reach out to Joe and get him on the line. I think he could address that far more clearer than I could.
Sure. Joe is one of the compliance experts from Sharps Compliance Incorporated. And we're unmuting him right now. So just bear with us 1 second. Okay, Joe, can you hear us?
Yes, I'm here. Can you hear me?
Great, yeah.
Yeah, good morning, everyone, or good afternoon, depending on what part of the country you're in. Still morning for me. Yeah, with inhalers or with aerosol cans, by DOT, those are items which you cannot put into a receptacle. They cannot be collected and mailed back and mixed with the other types of pharmaceuticals that would be put in there. So we always recommend you either have a separate collection receptacle for that, and we can, set you up for a hazardous waste pickup for those items, or if the participating location, be it a hospital, has their own hazardous waste program in place, they could collect those aerosols or compressed gases and put those into their collection program that they have that's separate from the collection box.
Great. Thank you so much, Joe and Dustin and our pharmacists. So our next question is whether the New York State Bureau of Narcotics laws make it illegal for hospitals to take back patients controlled substances for destruction at a later date, regardless of the DEA's regulations. And Joe, I don't know if you can speak to that, but from my knowledge, New York's Governor Cuomo signed away any prohibitions that were blocking the DEA rule from taking effect in New York about a year ago now. So hospitals and pharmacies are allowed to collect patient-generated waste pharmaceuticals, including controlled substances. And Joe, did you have anything to add?
I was just going to say, yes, that's correct. In New York, they can be collected from the ultimate users, which are typically the patients or the households, and they can be put into the collection boxes, such as the ones that the pharmacies on this webinar have in place. And, we can manage those through our collection process, through the special permit that we have, which is a MMS special permit authorized by the DOT to have those shipped to our facility for treatment. So with the new MMS special permit, the pharmacies or the collection facilities themselves will not have to become party to the permit. That's something that we control, and since it's a manufacturer, mark, sell, and use permit, the end users or the collection facilities will not have to apply for a permit as they may have had to previously.
Thanks, Joe. And that speaks to another question that we got here from an Ilana. She says, I don't understand what the DOT special permit is for. Brianna said she shipped stuff to Sharps compliance via UPS. So just to take a step back and explain why we brought up DOT regulations, under the DEA, take-back programs at pharmacies and other locations that are allowed to collect are able to ship their collected materials by common carrier, so someone like UPS, or those can be transported directly by a reverse distributor that picks them up and trucks them. Now, according to DOT rules, anything that is potentially hazardous has to be marked as such when it's being shipped commercially. But according to the DEA, it's best to ship these things discreetly so that it limits the risk of diversion. Now, to reconcile those rules, the DOT came out with a special permit and approved a special permit for, at this point, for a few reverse distributors, which exempts them from having to mark these things as hazardous, because the fact is the contents of these packages cannot be inventoried. They have not been inventoried, but it's important to ship them discreetly to avoid any diversion or possible mishandling. So the DOT and the DEA worked this out with reverse distributors, and at the beginning, we're asking pharmacies to apply for party status to these approved special permits. The newest special permits that have been approved for these reverse distributors, they encompass the pharmacies already. So the pharmacies don't have to take any steps to be in compliance with the DOT rules. Joe, do you have anything to add there?
No, just, we always want to be in compliance with DOT. There were some questions on the materials that are being placed into the receptacles. DOT is very concerned about classification, making sure they understand what types of materials, especially hazardous materials, might be in a container that's being shipped over the public highways. So we worked closely with them. We had a program in place. We redeveloped and re-energized a dialogue with the DOT, and they authorized a MMS special permit, as I said, which allows us to continue to use the same procedures and policies that we had in place previously. There's no changes, but we do mark the containers now with our MMS permits, and we do some training just on the procedures, which is actually the instructions for use on how to use our collection receptacle and aligners. We just make sure that the pharmacies understand that, as we have in the past. So, we have that MMS permit or special permit now, so we're all set to go and compliant with both DEA and DOT requirements.
Okay, thanks, Joe. So you guys have heard from one reverse distributor, Sharps, who we work with for this pilot. But as we said, there's information in the how-to guide that will remind you what's important, and we encourage you to speak with whatever vendor you work with in order to ensure that you're in compliance. So our next question is from Vincent. He says, our local Walgreens district manager is telling us that collection boxes can only be placed in pharmacies that operate 24/7. Is this accurate? Thanks for the question, Vincent. From my understanding, that is not accurate. Walgreens is choosing to operate their take-back programs in their 24/7 locations, but as long as a pharmacy closes its doors and closes its receptacle at the end of its business hours, it by no means has to be a 24-hour business just to host a take-back receptacle. So I hope that answers your question. Now a couple questions about cost. From Elaine, we received a question asking, do customers have to pay postage to mail unused or expired prescriptions? Elaine, I'm assuming you're asking about the mail-back envelopes, and that actually depends. The way our pilot ran and the way several pharmacies around the country do this, they offer prepaid envelopes. So the mail-back envelopes are always pre-labeled, but pharmacies can choose to make them prepaid and absorb that cost. There are pharmacies, however, including, I believe, CVS, that sells mail-back envelopes to their customers for a price. Mail-back tends to be a great supplement to take-back receptacles, like we said, to help serve the homebound or differently abled population, and sometimes in areas where folks don't get to the pharmacy that often. But we find that they are much more expensive per capita, so the receptacles tend to be a more cost-efficient option. But we like to use them in combination to make sure that we're serving all residents of a community. Our next question from Julie is also about the cost of the program. She asks, what is the cost of the program and what happens to the waste? Do you have specific security measures in place to address the controlled substances? So Julie, I can tell you that the cost of our program, our pilot program, is included in the how-to guide, broken down by the sort of bare necessities of a program like this, including a receptacle, and then some additional things that we did for our program, such as a big outreach campaign. I can tell you that the cost of renting a receptacle, as we did for this, which included an automatically scheduled liner replacement to come to the pharmacies on a predetermined date, that will run you between $20 a month and hundreds of dollars a month, depending on how frequently you want the liners delivered. So really there's a lot of variables that contribute to cost. The case study that we included here would have run each pharmacy, but the cost was covered by the project team in this case. It would have run each pharmacy $3,000 to $4,000 for an entire year, but of course that included mail-back envelopes, which, as I mentioned, are expensive, relatively speaking, and it includes the cost of an outreach campaign. So we encourage you, in the how-to guide, we encourage you to consider all of the different factors that can contribute to cost and ask vendors about the different payment options that they have. And I would love to throw this question out to our pharmacists to see if they have anything to add, in particular to Diane, since the hospital will be taking over the cost of this take-back program after the pilot is over. Diane?
Yeah. Like you said, it definitely varies based on your collection rate. I'm anticipating that the program is probably going to run us around $3,500 a year. Like you mentioned before, all those things included in the outreach, like the prescription bags, I probably will not continue with just because we're not a retail pharmacy. The mailback envelopes, we'll probably keep some on hand, but it's likely we won't be able to sustain the cost of supplying them for free, so eventually there may be a charge associated with them.
Great.
And if it's an option, I may also, work with our hospice our hospice may want to purchase 50 envelopes for their patients or clients. So we might go that route.
Thanks, Dan. And also to our pharmacists, another question from William, and we'll start with Brianna, please. What was the average frequency of filling the container, your receptacle liner? What was the average frequency weekly? What was the average frequency monthly? Can you speak to that a little bit?
Well, I know usually by the time, because we were set up on the monthly of getting a new liner, by the time we got the new liner in, we had a full liner in the other one. The other one, a lot of the times I would have to put the very top meds, dump them into the new liner so that I could seal the box without it being misshapen. But,
so about once per month, you would say?
Yeah, I would say
okay.
As weekly-wise, I have no real say other than when the box got full.
And
Diane, do you have anything to add there from the hospital?
Yeah, I think we just put in our 6th liner. So we did have a lot of downtime where we were locked. I think each liner typically was lasting us from anywhere from 5 days for the first one to 8 days on average being full. So we're filling them up rather quickly.
Great. We have a question from Adam about our how-to guide, and the question is whether it is specific to New York State and how much of the material applies nationally. Adam, our how-to guide includes a case study on this New York State pilot, but the guide is intended to be used nationally. So all of the information would be really helpful to anybody across the country interested in starting a take-back program at a pharmacy. That said, we would encourage you to look into your state-specific rules and regulations. Our next question is from Eileen. Actually, we've already addressed that question about auto-injectors. Our next question is from Molly. She asks, did you experience perception barriers or concerns from the state? She said it sounds like the pilot program was instrumental in building confidence in the take-back program. So would either of our pharmacists like to speak to that? Did you experience any perception barriers or concerns from community members or from anyone in the state?
We, at the Falls Pharmacy, we didn't receive any from anybody. All we had were customers asking questions about what could go in and what couldn't go in the box. Other than that, we didn't have any.
And same here at the hospital. No, it was every one that we came across, whether it be an agency or a resident, it was all positive, everything.
Yeah, and I'll add that we did have a member of our advisory committee from one of the regional offices of the New York Department of Environmental Conservation, just keeping an eye on things from the perspective of compliance. And PSI benefits from a very wide network of government members and many partners who are really familiar with the state and local laws as well as from the national level. So we were able to turn to a really diverse expertise on that to make sure that we were compliant. So we really didn't get a lot of, we really didn't see a lot of barriers there or concerns. That's one of PSI's strengths, is staying up to date on the regulations and rules around these programs. So our next question is from, let's see. It's from Bill, and his question is, what was the cost of purchasing a collection box, and does PSI have a list of vendors where the receptacles may be purchased? So Bill, the list of vendors, which is not exhaustive, but it's a pretty long list, is in the how-to guide. And the cost of purchasing a collection box can vary quite a bit. In this case, we were renting the receptacles, so our monthly fee for the pilot for each pharmacy included the rental as well as the replacement liners and the destruction of the collected materials. You can purchase a box, and from my understanding, they run anywhere from $500 to about $2,000, depending on the size and the amenities. But it's definitely worth contacting some of the vendors in our how-to guide about the specifics. So a question for Diane from Calliope. Is there a bottom line cost associated with the program that you operate monthly? And can you make a note about the census population, the demographic data in your area?
Census information. Well, we're a very small community. I actually did have this information, but I don't have it handy now. We're a very small rural community, and I'm sorry, I can't speak to the population at all. I'm not actually from this town. But basic monthly, just basic monthly cost, is that what it was asking?
Yeah. A bottom line cost.
Bottom line, I'm going to need either a bigger receptacle or more liners. So I'm anticipating anywhere between $250 to $300 a month. Okay, good to know. And I can tell you guys that the county populations are, one of the counties is about 250,000 and the other is closer to 60,000. So we're looking at rather small counties, lots of towns and villages, a total of about 300,000 in the entire target area for our project. Our next question is on outreach methods. It's from Ed. He says, what outreach method was most effective according to the results of this project? And I will first turn this over to our pharmacists, and then I'll take a crack myself. So, Bree, can you speak to what outreach method you felt worked best in your community?
I believe the newspaper, like Diane said before, just because that is, with our small community, that is how a lot of people get information, is through the newspaper or through the news, which social media being as out there as it is now, a lot of the news programs are on social media. So again, news and social media.
And I agree with Brianna. Newspaper, I think our survey results showed 35% newspaper, 24% radio advertisement, and 14 or 16% of residents heard about the program through flyers.
Great, thank you. I can tell you that from our surveys on outreach, unfortunately we didn't get back as many tear-off survey responses as we would have liked, but unsurprisingly, I think most people heard about this through word of mouth or from their pharmacy, either from their pharmacist or by seeing the receptacle itself there. A lot of folks also had a connection to the pharmacies or the hospital through a relative. So it seems to be that at least in these rural communities, word of mouth is really, really important. We also heard from some of our other pharmacies that aren't on this call that the pill bottle stickers, so tiny, brightly colored stickers that go right on the prescription bottle, those are really helpful reminders. They're very simple, and they just say, remember to return your meds where you got them. And our prescription bags in which the bottles are placed when they're given to the pharmacy customer, those were also really helpful, and they flew off the shelves. They're really useful for pharmacies to have. They're just printed with the information about the program, as I think Diane's presentation sampled, it demonstrated. So another question here for our pharmacists from Ed. How important is it to ensure that a box is not taken out of service? Diane, maybe you want to take a crack at that first and speak to your experience in the hospital, because I know at the very beginning we were really overwhelmed by the need in the community, the disposal need for pharmaceuticals, and we were getting a lot more than we expected.
Yeah, I mean, it's very important you don't take it out of service. We saw firsthand patients started to leave bags of medications on the floor and on top of the box, and we clearly do not want that to happen. So the least amount of time that you can keep that box locked, the better it is.
And Brianna, do you have anything to add to that?
We didn't actually have any real issues where we got the box full. By the time, like I said before, it was full, the new liner had already come in. So we didn't see the same amount of traffic like Diane said they did. We received traffic, but not like that.
Yeah, that makes sense, a standalone pharmacy versus a large hospital. And I believe that's one of the things Dan spoke to in her presentation on the differences between a hospital and a standalone pharmacy and how you can account for those differences in the collection system that you choose. Our next question is a follow-up to that. How often did you need to open the box to see if it was full? I'm sure that you both learned through the project, through experience, about how long it would take to get full. So how often did you actually unlock it and go through that process with your employees to check?
I can speak to that. We actually did not check the box. You could tell relatively easily if it was full or not. We locked it at the end of every day when we leave, so just the handle on the little drop drawer, you could kind of tell if it was sticking or not. So we just, when we were having difficulty opening it or unlocking it or locking it, you kind of knew it was getting full.
With us, we checked it periodically throughout the month. About halfway through the month, I would check, open it up, and just see how full the box was. But other than that, we usually, after about the first 2 months, once we realized it only took the full month, then we just waited until the new box came in.
Great. Thank you both. And can you both speak to what method you thought was more successful, the receptacle or the envelope? And by successful, I suppose the question is which one was more popular?
I would say the receptacle, just because we had some customers getting the envelopes, and I just didn't see as much traffic customer-wise with the envelopes compared to coming in and dropping meds in the box.
And on this end, I agree, the receptacle as well. I mean, we had a good turnout on the envelopes, and we had a request for more envelopes, but primarily that was used when the box was full. So I think if the box had been available, we probably would have collected even more.
Yeah, and from our end here at PSI, tracking the collection data from Sharp's compliance, I can say that that reflects your experience. It seems that the receptacles were the more popular or perhaps more obvious choice for customers. Another question for both of you, what questions did your customers have for you about the program, either the receptacle or the mailers? And were there one or two specific questions that you got regularly?
Any questions I received in the hospital side came from residents in terms of what they could actually put in the box. Or what do you do with needles? What do you do with your Lovenox or anything like that? Really specific questions.
And that's the same on like our end too. We just had customers asking what could go into the product or into the packages and into the box. Other than that,
and everybody wanted to know, is it okay to put controls in there? Controls was a big thing because just historically, everyone knows that people don't take controls back. So that was something else that had to be reiterated. Yes, you can put controlled substances in there.
Great. Our next question is from William. He asks, how is contamination in the bins dealt with if identified upon collection? For example, loose sharps, aerosols, or some of the other prohibited items that we mentioned before. And I can actually tell you the answer to that, William. The rules state that the pharmacies, the pharmacists are not to inventory the contents of their receptacles or obviously of the mailback envelopes since they never see inside of those. So anything that goes in is shipped off and dealt with according to DEA best practices for destruction, which at this point is still thermal destruction or in some cases energy from waste. So any so-called contamination in the bins would be dealt with at a level capable of safely destroying all of those contents together with the allowable contents. So our next question is from Hillary, and it's actually very similar. It asks, what percentage of drugs received in the Take-Back program were actually controlled substances versus over-the-counter? And Hillary, I can tell you that the answer to this is the same as my answer to the previous question, that it's very hard to know since pharmacists are not allowed to inventory the contents. But perhaps Bree and Diane can speak to their impressions, whether customers came to them with more questions about one versus the other. Diane, do you have anything to say?
Just from our past experience with our take-back events and the amount of medications people dispose of, I think it's just everything. I don't think definitely people are not just using it for controls, they're using it for everything. And at a glance, you know, when you do open the box and go to tie up the liner, there's over-the-counter stuff, there's just everything.
Great. And Brianna, anything to say? Anything to add to that? Did we lose Bree there?
Yeah.
Collection of controlled versus non-controlled. Did you get a sense of whether your customers were more interested in disposing of controlled substances or non-controlled? I can tell you that from PSI's perspective, in our 10 years of experience with this, we find that in general, consumers are not in a position to tell controlled from non-controlled substances, and that was one of the biggest reasons to push for better regulations that allowed both to be disposed of together. It simplifies things and it makes it easier for people to dispose of both, in particular controlled substances. So let's move on to a question from Julie. The question is, what is the end disposal for the waste? And I think that that's a great question to toss over to Sharp's compliance. So I'm going to ask Susie to help me out here and unmute some of our reps from Sharps, and maybe Joe, Dustin, or perhaps Jan Harris can speak to that. Are any of you on the line and able to speak to the destruction fate for the waste collected through a Sharps take-back program like this?
Yes, this is Joe, if you can hear me.
We can hear you.
All right. The inner liners from the receptacles are shipped back to our Carthage, Texas facility. Our facility there is a DEA reverse registrant, and we also have on-site an incineration facility. So all the material that comes back to our Carthage facility is placed into our incinerator, which is permitted to burn DEA-controlled substances as well as other materials. It is a municipal solid waste permitted incinerator, and that's how we dispose of the discarded pharmaceuticals, by incineration.
Great, thank you so much. So our next group of questions all have to do with packaging around pills and medications. So there's a question from Megan and one from Thomas asking whether people put loose pills into the receptacles or whether they are disposed of in their original containers. I can say that in the case of this pilot, there was no rule stipulating that the pills had to be loose, so they could be placed in their containers. But from the perspective of the pharmacists, did you run up against this issue at all, or this question from your customers?
We had it questioned as to whether they should put them in either way, and we told them it gets incinerated, so HIPAA law compliance-wise, everything, nobody's looking at the actual information. It's putting the box right into the incinerator. So we just had our patients throw their pill bottles into the receptacle.
And Diane, do you have anything to add?
No, the same here. I've seen patients bring it in both ways.
Okay, so that addresses a recent question we just got in about how you manage the HIPAA issues. So because the contents of these receptacles and envelopes aren't inventoried, there is really no issue. The inner liners get sealed up, shipped for destruction, and there's no breach of anyone's personal or private information. So the next question is from Elaine, and it's, what would you do if you don't order more liners for the box? So I think that question is asking what happens if you get caught without a new liner when your old one is full. And Diane, I know we came up against that at the hospital, so maybe you can reiterate or give a little more detail about that.
Sure. So there's always the option of ordering an off-schedule liner for a fee. Or, like I mentioned before, when we lock the box, we put the note up there, try to put when the next box will be available, and we offer to take back envelopes at that time. Or they can go to another facility that has a box.
Great. And I can also add that there is the option to pay as you go with some vendors. So you don't have to pre-schedule them. You can just wait until your receptacle liner is full, and that's when you place the order for a new one. Now, we chose to do, for this pilot, we chose to do a pre-scheduled automatic liner replacement, which had the benefit of hopefully always having a new liner available, but the downside is it required a little guesswork at the beginning to figure out how often they would be needed. So when we worked with Sharps, we were able to adjust the liner schedule as needed, but certainly with some vendors, if you pay as you go, while you wait for your new receptacle liner to come in, you would just lock up the access chute, the slot that consumers can use. You would close that up and put a sign on there to let them know when it's next anticipated to be open, like Diane said. So our next question is whether either of the pharmacists explored having patients empty their medications into a baggie prior to disposal in the collection box, and then separately dispose of the recyclable material nearby. Since I worked very intimately with both pharmacies, I can tell you that we didn't do that, but I know that it is done elsewhere in the country. And Diane and Brianna, did you ever have questions about that from your customers, or was there interest in doing that?
Well, I know for a while one of the local churches was collecting pill bottles that the labels had been cleared off of. But other than that, we have no real way, HIPAA law-wise, to dispose of the plastic pill containers. So we always had them just throw that into the box. That way it went through the HIPAA law compliance. Otherwise, they would have had to, yes, put them all in a baggie and then take all of their pill bottles home with them. And that just didn't seem like the right way to go at the time.
At the hospital, it never came up, but it certainly may help save some money in terms of liner space. Recycling the bottles would be a good idea, but I think without having somebody to help the customers,
stand right there and monitor.
Right, like we can't see the box, so without addressing that with them and guiding them, it would be hard to do here at the hospital.
That's great insight. Thank you both. One last question. Well, actually, it's a comment from one of our participants who noted that if you're out of liners, any heavy-duty cardboard box with an opaque plastic bag on the inside will meet the requirements of a liner. It just needs proper labeling. So that is something to consider, and certainly you have to make sure that you meet any DEA standards for the structure of said liner, DEA and DOT, since that liner will likely be shipped. But it is a great idea in a pinch. So thank you for that comment. And thank you all for your great questions and comments during today's webinar. We're coming to the end of our time here, so I want to give a special thanks to our terrific guest speakers, Brianna Flynn and Diane Loftus. To the rest of you, you should all be aware that our webinars and web conferences are taped, so you can access them if you miss any or if you want to listen again. The recording of today's web conference will be posted within about 24 hours on our website. And you should have already received a direct link to the web page, but you'll receive it again via email at the close of today's webinar. To access the recordings of other webinars that you may have missed, you can just go to productstewardship.us, click on Events, and then click on Webinars, just like you see on your screen. As soon as today's webinar ends, you'll see a webinar evaluation form appear in your browser, so we would greatly appreciate you taking just a moment to provide us with your feedback, because your opinion really matters to us, and this survey helps ensure that we can continue to provide you with this kind of excellent content in our webinars and our web conferences. If you accidentally close out of it, no need to worry. You will receive a link to the evaluation in a follow-up email as well. PSI's next fall webinar will focus on extended producer responsibility, or EPR, solutions for managing packaging waste, and that will be in October. The first one will be in October, and it will focus on recycler and waste hauler perspectives from British Columbia's packaging EPR program. So you can register for that now on the PSI website, and then PSI will hold another packaging webinar in November, where experts will discuss impacts packaging EPR programs can have on the cost of goods and packaging design. So stay tuned to your email for the registration link in the next week or so, because we would really love it if you could join us for those. So once again, thanks to our panelists and to all of you for your participation today, and have a really great afternoon.